Thank you very much for the kind invitation to be here. So I've been asked to speak on mechanical support in children in this country. So these are the, all right. So, so these are the 5 main types of mechanical support that we have used, given the challenges of doing any of this in this country. So I should share my experience with each of them. Um, Despite the known drawbacks of ECMO, this continues to be a very important mainstay of mechanical support for the very simple fact that it's more affordable than most others. So I'll divide the usage of ECMO in our practice into various indications. One important indication is for resuscitation from cardiac arrest. This is an example of an 8-year-old girl who was being followed up as a dilated cardiomyopathy, presented to the emergency room pulseless, and she was massaged and taken to the operating room and put on central ECMO. And after 3 weeks of central ECMO support, her ventricular function had recovered, and we did a biopsy and that showed viral myocarditis. And with some steroids, she completely recovered her ventricular function, was sent home. This boy was awaiting with restrictive cardiomyopathy, was waiting for a transplant, and had a cardiac arrest, was put on peripheral ECMO. And after, I think, 4 weeks, his femoral artery avulsed, and I think that day, Dr. Ganapathy was in the intensive care. So we were able to take him back and put him on central ECMO. And after 6 weeks of support, we got a donor heart which looked like this, which was turned on by 9 different units. And eventually we accepted it. He did very well. And this is him after 2 years. And this boy, again, is an overseas patient. 5 years ago, it was possible to do some overseas children. He had 3 cardiac arrests. The longest duration was 45 minutes. Early morning in January, so he was put on central ECMO. He was decerebrating for 3 days, woke up after 4 days. After 2 weeks of ECMO support, we had a donor with a ventricular function, which looks like the one on the right side. The donor had a cardiac arrest for 10 minutes. So literally a DCD heart. So post-transplant, at night, he required, again, another ECMO support for a few days. The ventricle completely recovered. They were shifted to the room, and after 3 weeks, his right ventricular function deteriorated with 3 tricuspid regurgitation. So we took him back to the cath lab thinking it was a rejection. It turned out to be a donor-derived coronary artery disease. The donor was 40 years old. So he underwent stenting of the LAD and right coronary. And during the procedure, he had another cardiac arrest. He was put on ECMO a 3rd time. And 3 weeks later, completely recovered. He came back after 1 year with restenosis with reangioplasty. And this is him after 4 years. We published this, and eventually he had a elective heart transplant in his own country and is doing well. I think this is what I would call a biological bridge to transplant. In the end, it turned out well. We use ECMO very often as a bridge to transplant. The girl this is for a single ventricle with severe ventricular dysfunction. The girl in the middle is smiling because she just heard news that she got a heart. We also use it for severe right ventricular dysfunction, secondary to pulmonary hypertension, where we use a VA ECMO. This is a girl after recovery. Increasingly, larger number of heart and lung transplants are being done in this country because of neglected long-standing congenital heart disease. So the waiting time for donation in this category is high. So we have figured out a way of ambulating these patients despite being on VA ECMO. ECMO is also used for primary Gulf dysfunction, RV cardiomyopathy in an 8-year-old girl. Had a cardiac arrest, was resuscitated with ECMO. We got a donor after 4 days. Pediatric donors are rare, so we accepted this heart. The heart didn't beat at all at the end of the transplant, but after 48 hours of support, she was weaned off, and in 4 days' time, usually young donors, the heart recovers almost always. This is a more recent example. During COVID, the number of donations were very less. This 14-year-old girl was airlifted from Delhi, had again a cardiac arrest soon after landing, was resuscitated, was on biventricular Centrimag, almost 3 weeks. And we got this heart from Surat, hypertensive with a significant ventricular hypertrophy. But there were no donations to be had, so the heart was accepted. And the heart didn't beat at all. We've never seen this. Ischemic time was more than, I think, 5 hours. at that time. She was in central ECMO for 9 days with the chest open. And she was weaned off ECMO, the chest was closed. And we had to reinstitute a peripheral ECMO after 6 hours in the middle of the night. Eventually, the ventricle completely recovered, and this is this girl after, now she's completed 2 years. We used the impeller pump. This child was transferred from Belgaum on an ambulance on a VA ECMO after having sustained a cardiac arrest. So we had no idea whether the RV was functioning or not. So we put in an impeller pump and then weaned off the ECMO, and effectively, after 3 weeks, she got a donor heart. She's done well. So over an 8-year period, we've had 24 patients ranging in 4 months to 15 years who had a cardiac arrest, were resuscitated with VA ECMO. The duration of CPR ranged from 6 minutes to 50 minutes. ECMO support was from 1 to 111 days, with a mean of 18 days. 5 patients had delayed neurological recovery after cardiac arrest, and we have a 66% one-year survival. So the strategy of transplant and ECMO or short-term support can be justified if a donor can be procured within 6 weeks to 2 months and the presence of biventricular disease. We also use CentriMag extensively. It's a very brief video. I will not bore the audience. We prefer to do that through a left thoracotomy. We used it in pediatrics, and the youngest is this 8-month-old child. We use Rotaflow in very young children as young as 1 month old. We use Berlin heart in one patient. Berlin heart is expensive, and more than that, the patient needs to be in the hospital and cannot be discharged. This is a child with biventricular dysfunction. We prefer to put a graft extension to the Berlin heart arterial cannula, which makes it easier to stitch. Especially if it's atrial cannulation, it's better to cross-clamp the aorta and do it like a mitral valve replacement, because it's very difficult in a very small chest. The Berlin heart cannulae are big and bulky and very stiff. It's not like a venous cannula that you can push in. And these are big tubes, as you can see, because the pulsatile pump, the size of the cannulae that you use are much bigger than what you would use for a CentriMag or a continuous flow pump. So driveline sepsis is an issue if they are followed up for a long enough period of time. And this child waited for 6 months before we could transplant. We have had long-term VADs being used. We've used HeartMate 2 for bigger adolescents. HVAD is possible down to 12 kilograms, and HeartMate 3 is possible in 20, 25 kilograms and more. This child, 3 years after an HVAD implant, she had a cardiac arrest, ECMO, CentriMag. She's doing well. This is 9 years after LVAD. He was 11 years old at the time. Both are Medtronic HVAD pumps. This is the youngest continuous VAD we've implanted in a 4-year-old child. She underwent a successful transplant later. So one of the problems is we don't really have a good solution for long-term VADs in children. So especially when you refer a patient who is not a candidate for a transplant and you don't have long-term external pumps which can be used realistically, we started using virtual reality as a tool to look at the feasibility of being able to implant these VADs. This 10-year-old boy was airlifted from another center in an air ambulance on a 6-hour flight. He had a history of cardiac arrest with multiple inotropes. He was lapsing in and out of consciousness. Very high BNPs of over 23,000. And this is what the ventricle looked like. Enormously dilated right and left atria with very, very short length from the mitral valve to the apex of the ventricle. Ventricle is small. Right ventricle is bigger. And this is the cath data. The pulmonary artery pressure is 55 by 38, wedge of 24, TPG of 20, with a PVR of 14.2 good units. So it's certainly no candidate for a transplant. And VAD is not possible. Transplant was impossible. Medical treatment was rolled out. What kind of a VAD can fit into the small chest with such a small ventricular cavity? Especially the distance from the mitral valve to the apex of the ventricle is very short. So I took help from our colleagues in the Indian Institute of Technology, Madras, and we did a virtual imaging and created a VR image of the CT scans along with the HVAD. And we implanted it ahead of the surgery virtually in the lab. You can put on those glasses that you use the children use for PlayStation. And you can actually implant the VAD multiple times and choose the right site for implanting the VAD so that it doesn't impinge on the rib cage and doesn't touch the mitral valve. You make sure that the implant is possible and that it can close the chest. Registration is possible because you can locate the position of the left anterior descending artery and choose a site in the ventricular apex ahead of time, so that it makes it easier to choose the time of surgery. So this is the X-ray of the boy at the time of transplant. He's in pulmonary edema, as you can see the X-ray. The lung fields are wide. The systemic pressure is 89, the pulmonary pressure is 84. And this is the, typically you don't see a RV which looks like this in a VAD. So at that time, fortunately, HVAD is available. So we implanted the VAD and technically it went off well. And this is soon after the cross clamp is removed. As you can see, we're still dearing. The tip of the HVAD cannula is actually touching the mitral valve. That's how short the ventricular apex was. And the position was right, and this child did well. And post-operatively, with this technology, when you do a CD scan of LVADs, you have a lot of noise. But with this, you can eliminate the noise. You can actually walk through the pump and the ultrograph to make sure there are no kinks and no obstructions. And this boy did very well and is now a long-term survivor after 1 year. Our total MCS experience from 2012 to 2022, we've done a total of 389 ECMOs, out of which 226 have been arterial ECMOs, majority of them for heart failure of some kind. 65 of them have been children less than the age of 18. They use 74 mag LVADs, out of which 32 have been pediatric, and 20 rotaflows. And very young children use rotaflow because in this country, very young children, the parents cannot afford anything. Rotaflow is only 12,000 rupees. We used 81 continuous flow LVADs in our practice, 15 HeartMate 2, 40 HVADs, and 26 HeartMate 3, out of which 11 have been in children. There's one Berlin heart. If you look at the world map from South Korea on the east coast to the west coast of Africa, interestingly, the regions without LVAD and without transplant are shown. India and China are perhaps the only two countries where any kind of organ donation, the transplant programs are possible. And all those blue squares are countries where HeartMate 3 and any of these long-term VADs are not being marketed. So there are problems with the current situation, especially in this country where organ donation is skewed towards some geographic locations. Continuous flow pumps, the one which is Berlin heart is actually of no use in this country because you can't discharge them. So if you're going to keep some patient in the hospital for 9 months, it's not a practical solution. So you have to be able to discharge patients home, which is not possible with a CentriMag or any other pump. So the only choice we have now is a HeartMate 3, which costs over $100,000. It's too big for a pediatric patient. It lacks biventricular support. A lot of children especially have biventricular disease. And driveline infection is a huge issue, especially if you follow them for long enough duration of time. Beyond 5 years, the driveline sepsis rate is almost 80%. And strokes are a very important adverse event. We've not had strokes in children at the continuous flow pumps, but in adults it's still an issue. Despite the great enthusiasm for HeartMate 3, if you look at the momentum trial, and if you look at this stroke analysis, a lot of important information is buried in small print. The difference in stroke rate between HeartMate 3 and the other pumps is not very significant in the first 180 days or first 6 months, which really means that if you cross the first 6-month barrier, then you're okay with stroke rates of less than 10%. So that's a big bridge to cross. In fact, there's some evidence that the early stroke rates in HeartMate 3 are more catastrophic, as you can see in the slide. We've had early strokes in HeartMate 3 that we never had with an HVAD. One of the things that HeartMate 3 boasts of is a wide gap of 1 millimeter. And that very thing, which is a big advantage in preventing pump thrombosis, could be on a side because small bits of muscle or small bits of clot can actually escape through those large gaps and cause. And the strokes are more catastrophic in HeartMate 3. So when we compared, I'll speak about a transplant outcomes in the next talk. I believe I have one more. So when we compare our transplant with VADs at 20 months, there's pretty much no difference. Around 3/4 of them are alive. But when you follow them up to 7 years, the continuous flow pumps had pretty poor outcomes. I must confess that this was on the basis of HeartMate 2 and an HVAD. The recent HeartMate 3 will give you longer survival, especially in children, remains to be seen. And look at the hazard ratio for LVAD use for medium-term survival in our program is 1.68. And this is the hazard estimate. When you do a transplant, the hazard curve comes down. So if you cross 1 year, you're pretty much likely to cross 5 years. And the next deadline comes around 10 years when you start getting vasculopathy and stuff. In LVAD, after you cross the first month, is go home. Then the risk increases. The risk of stroke at 1 year to 6 months to 1 year is still high. So we got interested. But through a chance meeting, I met an Australian engineer, and we started a project developing VADs together. The idea was to design and manufacture a pump with keeping cost as an important consideration each stage. We thought the pump should be small enough to be possible to implant, at least in pediatric, and certainly not in infants perhaps, but certainly in older children. And a biventricular support, especially with a single controller. So we designed a thinner driveline of 4.6 millimeters. We also working on a catheter pump. And all of them are supported by the same peripheral. That means a single control and single battery can support 2 pumps. This minimizes electronic waste and it allows you to implant them through the left chest. So the pump is ready. The HeartMate 3 is on the left side. The second one is the one we've developed. And we've completed several animal trials on the GLPs, that mandated animal trials going on. And we have several patents on this, including wireless transfer. Compared to HeartMate 3, which outflow graft is 14 millimeters in diameter, of inflow cannula is 21 millimeters. The pump we're designing has an outflow graft of 10 millimeters and inflow 16 for the LVAD and 14 millimeters for the RVAD. I believe that, especially this idea came to me because when you put in a CentriMag, a 30 French venous cannula gives you glorious drainage. 30 French is 10 millimeters. So why on earth would you need a 21 millimeter inflow diameter for HeartMate 3? That means you have to make a hole that much bigger, and that bleeds. So if you had a smaller hole, perhaps bleeding would be less, because one of the big things in a VAD is continues to be bleeding. So infant Jarvik, I understand it's not available for sale, and I understand recently a Japanese company has brought it, so I don't know when it'll ever reach the market. This is one of the children we did VAD followed by transplant. It's completely recovered. So in conclusion, the mainstay of mechanical support in children is ECMO in this country, and CentriMag and Rotoflow, HeartMate 3 and HVAD, HVAD of course not there. HeartMate 3 is a rarity. So we need dedicated long-term pediatric VADs are needed, and work is in progress. Thank you, and I'll be happy to take questions.